Thank you. Okay. Welcome everybody, and in particular, welcome to members of the public who will be joining this meeting virtually. This is the meeting of Sheffield Clinical Commissioning Group governing body, the public part of the meeting. My name is Mark Gamsu. I'm the Deputy Chair of the Clinical Commissioning Group, and today I am chairing this meeting because our chair, Terry Hudson, has had to send his apologies to the meeting, and I'll do formal apologies shortly. Okay, so I'd also just like to, well, we've got some people attending the meeting who don't normally attend. I'd like to just welcome Vicky Riley, who's coming, and I think Vicky, you're the only person who's here who doesn't normally attend the meeting, but I will be corrected now by Jackie if I've missed anybody out. No. Okay. Right. So the first bit is I'd like to do apologies for absence. And as I said at the beginning, we've got apologies from our chair, Terry Hudson, and also from Brian Hughes. And we have apologies from John McIlwraith, Nikki Normington, and Judy Robinson from Healthwatch Sheffield. However, Trish Edney has kindly agreed to step in and cover for Judy, given that she can't make it today. Now, have I missed, Jackie, any apologies that have today? Okay. I also note that we've been informed we're really pleased to have, particularly at this difficult time, Greg Fell, our Director of Public Health, present. Greg does have to leave the meeting early for understandable and obvious reasons, I'm sure. So, okay, so that's it. So the next bit is I'd just like to check for, and we are quorate in the meeting. So I'd now like to just check for conflicts of any declarations of interest with regard to items that are on this agenda. So at this stage, can I just ask, can anybody indicate, is there anybody who wants to indicate that they have a conflict of interest or a potential one? And I can see nobody indicating that. So I think we can move forward and record that there were no conflicts of interest declared. Next item is questions from members of the public. We've not been notified of any questions, so we'll move straight through that and on to the minutes of the previous meeting. The only thing I would just say, just before we do the minutes, is members will have noted that almost all of the items that are on the agenda today are for noting. So clearly, there's I think one recommendation for action. Now that doesn't preclude if governing body members, if they think that there's an area where they feel that further action might be required, from suggesting an action. But I am just noting that given that, recognizing that given that all the items here are for noting, the key bit is I think the key role for us as governing body members is to be testing A, our understanding, and B, whether we think the information here is sufficient in our assurance role within governing body. So minutes now from the previous meeting, and that is the meeting that was held on the 4th of November 2021. And first of all, if I can just check for accuracy and go through, I'll just shout out the page numbers: page 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14, 15, 16, 17, 18, 19, and that brings us to the end of the minutes. And nobody has raised any points of accuracy there or areas requiring clarification. So I think, first of all, could we just record our thanks to the minute taker for those minutes, which, as everybody will have heard, that's 19 pages of minutes, not a single point being raised with regard to accuracy. So if we could record our thanks to the minute taker for that, please. And we'll now move on to matters arising. And again, this is quite short. Just looking at the action points and matters arising. The first one is 122/19. Now, Brian Hughes was originally going to just update us on that. And this is a question with regard to levels of vacancies and agency staffing within provider services. Is anyone in a position to just update us on where we've got to with regard to that, or is that still open?
I just, I think it's probably the same positions we've previously noted, because we're not doing the normal reporting from providers, given they're all focused on responding to the current incident. It remains an open action.
Okay, thank you, Jackie. And that was Jackie Mills, who's our Director of Finance. The next one is emergency preparedness. And again, this is open. And I think it's down for you, Jackie, to.
Yeah, the initial action was down to me. However, that part of the action was closed at the last meeting. The subsequent action was for Cherry to have a conversation with Greg around how the declarations of the providers fits with the current EPR response. So I think that's still an outstanding action for Terry and Greg to have that conversation.
Okay, thank you. And then finally, 119/21 is recommended for closure. And I think we're saying here that all the actions have been completed with regard to this. Kath, is that correct? Yeah. Okay, thank you. So we're now moving on to item 7, which is a presentation from, I've got Alan Windle down and Lucy Ettridge, our Chief Nurse and Deputy Director for Communications and Engagement. Are we ready for that? Are we going to do some screen sharing and get that up?
Thank you, Chair. Alan Windle, Chief Nurse, Sheffield CCG. I think we've agreed that we won't be sharing screens and getting technical at this point, Chair, and I will fill in all gaps in presenting what was requested of us, really, of a Sheffield overview and the CCG primary care and agency response to vaccinations, if that's okay. So basically, people might be bored of me saying this, but I don't get bored of saying it. That Sheffield itself, within our vaccination programme, has the highest vaccination rates compared to our comparative core cities in England, and I think that's a fantastic position that we are in. The latest figures show that you are more likely to have had a first, second, and a booster COVID vaccine if you live in Sheffield than, as I've stated, other core cities such as Birmingham, Bristol, Leeds, Liverpool, Manchester, Newcastle and Nottingham. This achievement is testimony to the hard work of thousands of people in Sheffield who have been involved in one of the largest post-war efforts this city has ever undertaken. Primary care, trusts, the council, the CCG have worked around the clock to make this happen. Behind the scenes, there was an army of staff dedicated to supporting these efforts: practice managers, receptionists, planning teams, IT specialists, there to ensure that the smooth running of the actual sites themselves. And across the city, people gave up their time through to act as marshals, there to greet people as arrived at the vaccination centres and to guide our populations through the process. A huge part of our success, I believe, along with the dedication from voluntary sector, like I said, through the NHS and local authorities, is the additional investment that we made in organisations that could reach communities that were either less likely to have because of hesitancy or a need for additional support to gain access to clinics. We funded 26 local organisations to support living in poverty and deprivation, those experiencing homelessness and residents with disabilities, along with Sheffield faith communities and people from ethnic minorities backgrounds. These groups encourage everyone to get vaccinated. Free community buses, taxis have been provided to make it easier for people to travel to local sites. Volunteers and staff have made these groups and had conversations with people on their doorsteps. Virtual meetings and questions and answers were organised to answer people's questions. And even a senior executive from a vaccine maker, Pfizer, accepted an invitation to attend one such event and field questions about the company's vaccine. An incredible amount of time went into this work and continues to do so. We actively engage with people so that they could raise issues and barriers so that we could resolve them. We invite some messages to the vaccines were translated, appointments booked on behalf of those who were unable to do it, and people unaccompanied to their appointments. Getting a vaccine was made easier with pop-up clinics in mosques, churches, and local community centres, along with delivering in individual practices across the city. I think we're the only CCG, as I sit here today, that we funded a rap song even to encourage young people to get the vaccine. I didn't do the rap. Our partnership with Sheffield City Council has been an absolute vital to achieving what we have achieved. We have funded the same groups to continue their great work on boosters. The council have also funded VCS. The funding ensures that we covered all parts and demographics of the city and got to funding groups struggling to maintain services. I think another big accolade, and we do have the Director of Public Health on the call, is we also have the least gap between our most and least deprived as well in those vaccinations. So along with a fantastic vaccination programme, it shows that the efforts that we've achieved have also been well worth in reaching those hard to reach groups. Our staff have been brilliant too. And before Christmas, responding to the booster programme, we put out a calls to arm to help practices with the vaccination programme. Booking people into appointments, supporting vaccine delivery, you name it, everybody stood up. And testament to that, we have had a massive and a huge booster campaign just before and over the Christmas period. I just want to say, on behalf, I hope, of everybody on governing body and personal from myself, that both people working in primary care and our teams and our voluntary sectors and our local authority, a massive thank you from us, a huge thank you, because we're in a better position for it. Thank you, Chair.
Thank you very much, Alan. That's really helpful, and it's so important to capture our story. Later on in the private part of the meeting, when we're looking at preparations that we'll be taking to get ready for the inquiry around response, I think that it's really important that elements of that story get played in really strongly. Now, I've got two people with their hands raised. And what I'd quite like to do is, I'll come to Greg first. I just want to check, Judy, and Chris, before that. It'd be quite helpful if we could get a GP response coming back in a GP perspective, given how important primary care was. So can we kick off first of all with Greg, and then I'd just like to go and see whether a couple of GP colleagues might like to just give their perspective in light of what Alan said, and then I'll come to everybody else. So Greg.
Thanks, Prof. I'll be quick. So 4 things. One,
This is Greg Fell, our Director of Public Health.
Sorry, sorry, Greg Fell. Occasionally I know things about public health. 4 things. Firstly, everything that Alan said, you nearly made me cry, Alan, but I know your heartfelt meant that. Secondly, right back at you, because you've been on point coordinating this, and much of this has happened because of your efforts. So huge credit to you for making a lot of that happen. Thirdly, I absolutely endorse the Herculean effort, and definitely biggest effort City's seen since the war period. The acceleration in the booster campaign, which was already clipping along a really rapid rate, but watching that the rate of vaccines per day go up in the 2 weeks pre-Christmas, that was exponential growth, and that was the kind of exponential growth we do want to see, rather than what the other form that we have seen. Fourthly, agree on the learning, and there's something to be said about, to be fair, the government has well funded the sort of the engagement part of this, and there's something that we can all take away on how we have done this engagement and making that permanent shift in the way in which we work with voluntary and community sector. I think we can all reflect and learn from some of that, because I think that has made a real difference in the communities that we just wouldn't have reached otherwise. And learning, we can take that away and learn. I'll shut up there.
Thank you, Greg. Okay, so I'll just go to Ben first, and then I'll come back to Judy and Chris.
Yeah, thank you. So I'm Dr. Ben Allen, a GP board member. So I think the perspective that I'd kind of like to offer really is just how incredibly impressed I am by the staff in primary healthcare. We're absolutely exhausted. It's been such a really difficult few years. We could see Omicron coming. Everyone was just saying, look, we can't do any. Then when we saw how infectious it was, people just stepped forward and just took on even more work. And, to some extent, I think we're potentially a bit of a victim of our own compassion and drive, which is all centered around patient care and saving lives and making people's lives better. Because when we see that patients need us, no matter how on the floor we are, we pick ourselves up and we find a way to deliver what needs to be delivered. And that's just the story in so many surgeries. So yeah, that's remarkable.
Thank you, Ben. And sorry, and I did say I'd let 2 GPs say something. So Zach, and then I'm going to come to Judy and Chris.
You caught me by surprise there. There's a lot I'd like to say, but I think probably just keep it fairly brief. I think it's just to reiterate everything that's said. I think it's been a momentous achievement. I mean, it's absolutely fantastic, but it's everybody working together. And I think the great thing about this is that for the future, we've demonstrated how well we can all work together across the system. And I think that is really positive. And I do get a little bit frustrated that a lot of people are wanting to dine out on the success of the vaccine rollout. And I think it's really important that the thanks and gratitude goes to the people who deserve it. And that's the people on the front line. It's the support staff behind that. It's Alan, it's his team, it's Greg and his team, it's the colleagues in the council who have really helped us deliver this. And to be honest, sometimes in spite of the system above, which has made it quite difficult. So I think it's just really important that the credit goes to where the credit's due. And it's the guys, particularly on the front line, that have been doing this on a backdrop of extremely low morale because of COVID, but also some of the press criticism that a lot of colleagues have had over the last few months. But I think it's just a really good example, like Ben says, of a system pulling together to do the right thing. And I think the exponential vaccine rollout pre-Christmas was a really good example of understanding trust across a system, where basically our public health advice locally was that it's really important to get this done as quickly as possible. It became very clear that Omicron was very infectious. So you've got a little window of opportunity to try and vaccinate the most vulnerable within the population. It was so nice to be involved in that, even although I wouldn't take any credit for a lot of the frontline stuff. Just to see some of the conversations that were happening, the way the media were engaged, the way we were actually sort of working together across the system, I think in one weekend to deliver nearly 25,000 vaccinations. And I think the benefit of that, effectively what it meant was a lot of people, by the time we had the Christmas and the New Year free-for-all, in spite of a really high infection rate, had antibodies within their system. And I think hopefully over the next few months, the benefit of that will become quite apparent. So again, it's just to reiterate a massive thank you to everyone involved. But I think it does actually put us in a really good position for the future. I think we've demonstrated what we can achieve by the system working together. And I think it really lets us achieve a lot more, hopefully, in the future. So thanks to everyone.
Thank you. And okay, I'm now going to come to Judy and Chris, and then I'm going to let Marion have the final word. Don't forget to say who you are, all of you. And let's go to Judy first.
Thank you. Judy Thorley, I'm lay member with the CCG. I mean, obviously, just to echo what how fantastic the sort of outcome, if you like, of the great efforts. And I'm particularly pleased that that Greg, you're recognising publicly the huge effort that I know Alan has put in, along with other colleagues. But I know that he's taken the lead on that. The point I wanted to make was similar to yours, Greg, and you, Zach, around the learning. I think it's a huge opportunity that we now have, and we've already seen some of the learning being taken forward in other places, you know, building on what's happened as a result of the system and joint working response to COVID. And as QUAC chair, so the Quality Committee chair, I really look forward to having the opportunity to see how we can work together to embed some of that learning further to benefit the population. Particularly want to acknowledge the effort for some of our most vulnerable in our population and others who are hardest to reach. So yeah, look forward to that learning within the Quality Committee.
Thank you, Judy. And Chris, who are you? You're muted.
No. I'm Chris Neild, I'm a lay member on the governing body. I totally support the comments that have been made, but I particularly wanted to talk about the relationship between Sheffield communities, the voluntary sector and the statutory sector, and how the fact that we've got such trust there and willingness to step up when they're asked, especially when they're asked by their own GP practice to get involved, and all the other work that went behind, you know, as well as turning up. So I think that trust and the practical nature of it being local and what was needed and what we knew about that community that would support the uptake of the vaccine and our overall commitment has got to be recognised. It's outstanding, and it just gives me hope for future changes and the pressures, you know, that we're still facing, that we can come out of this in a better way, and how we go forward with this for the best of Sheffield community.
Thank you. And Marion, finally, and who are you?
Thank you. Marion Sloan, GP board member. I think this has shown Sheffield at its best. I think it's shown the CCG at its best, and it shows what a functional team we are. The CCG aims are to provide local services that are accessible to everybody, equitable for everybody, and there when people can get to them. So I think even single-handed GPs have had help from the National Booking Service. So if they've not been able to deliver this themselves, it didn't matter, because there's somewhere else local that has been able to do it. And all this has been done against the background where the system is running very hot. The day job has not gone away. Seasonal flu is at its peak. GPs are very, very busy. But teams of additional helpers have come on board, and we've had volunteers, we've had patients, we've had a dentist who's been vaccinating for us free. People have really stepped up to the plate. So the folks on the front line have been backed up by the IT gurus in the back room, and they sent out lists and phone calls and texts, and our practice manager, and I'm sure lots of others, have worked 4 weekends on the trot. It takes some doing to maintain this, and really, we've done it, and Sheffield, as you're saying, is in a much better position. What we are finding now is that we're down to the hardcore of people who are now saying, no, thank you. So that's another challenge, because we're coming to folks who say, oh, I'm not having that, you're not injecting me with that. So the day job isn't over. We've still got that need for public health messages to go out, because that's what people listen to. And they listen to peer groups and they listen to their friends. We've got a big job to do with pregnant women. The numbers of vaccinations there is modest. So we've done very well. The job isn't finished. We kept Christmas open. So I think that was a great achievement. But mid-January, we're hitting a bit of a hit from families mixing, probably. But I do think we've done well, and it's time to reflect and just say, well done, that team, but the job's not over yet. Thank you.
Okay. Thank you, Marion, and that's really helpful. And I just want to, there is one of the things I think we're meant to do, and I'm only saying this, is our chair has advised us that we shouldn't use the chat box, but there's some quite good stuff in the chat box. So I am just going to, I think, to conclude this by saying, and people have mentioned this, and I think it's really important that when, listening to what people are saying, and people, as Marion has and others have also said, this isn't about being self-congratulatory, but it is at all. It's about recognizing that, and I think everyone is consistent with this, is about saying the huge effort that agencies, commissioning organizations, the local authority and the public and the voluntary sector have all taken to actually respond to this terrible challenge. And Dr. Lee Salisbury has just pointed out the real importance of the way the population in Sheffield generally have responded to this. But nonetheless, there are some challenges associated that we've had to respond to, and some that we're still trying to address. And I just want our Director of Public Health to just come back and just maybe mention one of those challenges specifically, and then I'm going to move us on from this item.
Very briefly, I suppose there's the as yet unvaccinated. There's more than 100,000 people aged 12 or more who are as yet unvaccinated. Any vaccine is better than none. One is better than none. Two is better than one, etc. The thing that concerns me most is the anti-vax messaging. There's a lot of it about. It costs lives. There's mind. Lives. It shapes people's views and views, and it will cause people to not choose to be vaccinated when they otherwise would be. There's not a lot that we can actually do about that, but it is all over social media. What I consistently say to people, if they are worried, is I will talk to them one-to-one or in a group about what their worries are and address any questions that they have. The place I always point people towards is either a gov.uk website, an nhs.uk website, or, to be fair, the BBC have done a great job on vaccine information. I point people nowhere else than that. I think we all need to be mindful of treading very carefully around the anti-vax messaging, but not dismissing people's legitimate fears and worries, because they do have them. So we should continue to talk to people about those.
Thank you, Greg. Okay. I really welcome this discussion. I think it was a really good idea, whoever had it, to get this item onto the agenda, because I think it is important to take breath, but also to capture what we have done, particularly in this period of transition to the Integrated Care Board. It's really important that this message and the way that we work in Sheffield is understood and built upon going forward later in this year. So thank you very much for that. And it looks like, Alan, that there might already be something written down that we can be using here. So look forward to seeing that. Thank you. Thank you, everybody. And I'd like to now move us on and this meeting today is very much one of those meetings where we receive a range of reports about quarterly reports and so forth, and looking at in different ways at the CCG and the activities that it's taking and the responsibilities that it has. So the first one that we're coming to is the month 8 finance report. Jackie.
Thank you, Mark. So I will formally introduce myself, given that I didn't do it properly last time. So Jackie Mills, I'm Director of Finance for Sheffield CCG. And as Mark's introduced, this is the finance report to provide assurance to the governing body around our statutory duty to deliver financial balance. So the report's based on the position to the end of November And governing body members will recall that we approved a revised financial plan at our meeting on the 4th of November, and that was after confirmation of the resources available to us for the second half of the financial year. I am pleased to report that on the basis of that revised financial plan and on the basis of the latest financial information available, I am more assured that we will be able to deliver our financial position this year and deliver it's an in-year break-even position, which means that we will maintain our cumulative surplus of 21.9 million, which we had at the beginning of the year. And whilst I've moved the RAG rating to delivery of the financial position to green, I have highlighted in section 5 of the report that we continue to manage a range of risks and potential upside benefits. So we will need to carefully monitor and manage these, but at the moment, my assessment is that they appear manageable. You might also want to note that the draft planning guidance that was issued on Christmas Eve for 22-23 indicates that the cumulative surpluses of CCGs will be brought forward into 22-23 and transferred to the ICB. So that cumulative surplus won't be lost, although access to utilise that funding will be, as now, tightly controlled. And then the final element of the report I just want to draw to attention of members of governing body is the request for approval of budget movements over £2 million, which is why this report is in the for approval section. And that is just an adjustment that was made to the top-up funding for 2 of our Sheffield providers, which, in line with the final agreed ICS system plan, has been returned back to the ICS reserves. So sits within Sheffield CCG reported financial position as a host to the South Yorkshire and Baskerville ICS. So there wasn't anything else I particularly wanted to draw out from the report, but I'm happy to take any questions.
Okay, thank you very much, Jackie. And I'm just going to come back, and this might be my ignorance, to just clarify that last point with regard to, because I think this is the one report where there is a recommendation that we have to approve. But before I do that, and again, I think we're going to be going into a series of reports now that look at issues to do with commissioning, look at the planning update and governing body assurance framework, and all of those to some extent of finance, or are very much so affected by our financial allocation. And I just wanted to check in terms of clarity that we're still awaiting the final confirmation of the final financial allocation going forward, which obviously then have which means that some of the things that we're going to be talking about in the subsequent 2 reports, which require action, we can't be completely certain about that because we're not completely certain about the final financial allocation. Is that correct?
So just to confirm, so we received draft guidance and draft allocations on Christmas Eve. We await the technical guidance, the final issue of the planning guidance. That was initially scheduled for early January in the information received before Christmas. The latest information I received yesterday is that that won't be available at the earliest until at least the end of next week. So we're obviously moving towards the end of January for that information to be available. And it's that we need to actually understand the detail of the financial challenges for 2022-23. There's also elements of that information that's still awaited, in particular around funding for elective recovery, which is still awaiting. Is quite a big part of the jigsaw that we'll need to put together.
Thank you. And then just with regard to approved budget movements over £2 million, what I'm just clarifying this, I hope this isn't just me. Are we agreeing to approve that budget move, that in principle that's something that can happen, or are we talking specifically about some particular budget movements over £2 million? And if so, where is that in the report?
So it's a movement out of the block contract values for Sheffield Teaching and Sheffield Children's that we approved our November meeting.
Right.
When the final agreed system plan was agreed, that funding was no longer required to be allocated to those 2 providers. It will subsequently be allocated elsewhere in the system by the ICS. So it is an actual transfer of resources compared to the financial plan that was approved.
Okay, thank you. So, are there any questions for Jackie with regard to the report or points of clarification? I think, with the exception of me and my search for trying to get things clear, everybody else fully understood what you were saying. So thank you, Jackie. So can I just ask the board then to agree the approval that Jackie calls for in the recommendations? Can I have a show of hands, please? Show of hands, and we've got a yes and a thumbs up. So that's good. Okay, thank you. Right, so that now, if we can now move on to papers for consideration. The first one is paper 9, item 9, paper D, which is the planning update. And Sandy Buchan, if you can introduce yourself, and then you're going to just give us some highlights there.
Thank you, Chair. So my name's Sandy Buchan, I'm Director of Commission Development for Sheffield CCG. And this paper is to provide an update to governing body on the National Planning Guidance for 22-23. As Jackie said, it was published on the 24th of December. And it basically outlines the objectives that the NHS needs to deliver for next year. It is important to note at this point that the guidance is very much based on the scenario that by the 1st of April that COVID will return to low levels, and therefore there will be some significant progress made on restoring services and reducing backlogs. So it's very much based on that scenario, but as we know, we're very much in a very difficult challenging situation with COVID currently. So it's just to be wary that these priorities are based on that scenario based assumption. So the guidance itself outlines 10 priorities, and each of those priorities have a number of targets and requirements. They're detailed within the appendix of the paper. But the 10 priorities in itself are detailed in the main part of the paper. So that's invest in our workforce and new ways of working, respond to COVID-19 ever more effectively. So that's the vaccination programme and meeting the needs of patients with COVID, delivering significantly more elective care and tackle the backlog, reduce long waits and improve performance against cancer waiting standards, improve the responsiveness of urgent and emergency care, improve timely access to primary care, grow and improve mental health services, continue to develop our approach to population health management, prevent ill health and address health inequalities, exploit the potential of digital technologies, make the most effective use of our resources. And in relation to priority 10, which is to establish ICBs and collaborative system working, it was announced within the guidance that a new target of 1st of July 22 is now the new agreed date for the statutory arrangements for the establishment of the ICBs and the ICS, so to be legally and operationally established. And that obviously remains subject to the passage of the bill through Parliament. So that's an extension from the original 1st of April 22 date. And what that will mean will be that CCGs will remain in place as statutory organisations. They'll retain all existing duties and functions and will conduct their business through existing governing bodies. CCG leaders will work closely with designate ICB leaders in key decisions that will affect the future ICB, notably commissioning and contracting. And NHS England and Improvement will retain all direct commissioning responsibilities not already delegated. So I thought it was particularly important to note that was published alongside the guidance itself. So the deadline for the submission of the plans has been extended to the end of April with a draft plan in March. However, we are expecting further guidance to be published outlining the specific timetable and requirements. At the moment. That hasn't been published, and as Jackie said, is not expecting in the near future. But the guidance very much details and has a clear remit of what we're required to do for 22-23 or plan to be doing. So in relation to our Sheffield commissioning plan, we're continuing to develop a joint plan with Sheffield City Council as we did for 21-22, and the work of that is progressing. However, the current COVID challenges and pressures have impacted on the timing of some of this work, but that is still ongoing and very much aligns with the work that's detailed within the national guidance and those that's detailed within the NHS long-term plan. Jackie, I don't know if there's anything more you wanted to say on the finance section of this.
Probably not on the finance section per se, other than what I've said, apart from just to note the requirement for us to have contracts agreed with providers this year. So for the last 2 years, we haven't actually had formal contracts in place. The expectation is for the whole of next year, we will have contracts in place. And there is a bit of a hybrid move from the nationally calculated block contracts that we've had previously towards more normal contracting arrangements, but an expectation that a lot of the arrangements we've had in the current financial year will roll forward into 2022-23. And then just the final message is the draft allocations we have received do indicate a significant level of financial challenge. The efficiency ask of systems has increased significantly, and a lot of that is around the recognition of the additional resources that the NHS has received over the period of the pandemic. As Sandy said, the expectation or assumption in the guidance is that we will return to low levels of COVID, and so an expectation that a lot of those costs will come out of the system. So it will be a challenge for us to be able to release significant efficiencies, and will need to be a focus of both the CCG in the first quarter and as we move into the ICB around how we can deliver the many aims within the planning guidance, our local priorities, but releasing significant efficiencies at the same time. Okay, thank you. Sandy, is there anything more you want to add before I move us on?
No, just any questions?
Okay. Thank you. I think, again, just sort of testing out that in light of the discussion with regard to the previous item, again, this is more for, I'm sure everybody on this meet call will have already spotted this, but the members of the public, item 4.1, paragraph 4.1 just notes that, as Sandy has said that technical planning guidance and formal system financial allocations were not released with the main planning guidance and are yet to be finalised or approved. I mean, we heard from, I think, Jackie, that we've seen them in draft. So where we are with this, and it is, I feel, one of those things where we have to sort of say, well, we are where we are at the moment, which is we have some fine priorities that have been identified nationally, which I would suggest are pretty incontestable, really. The issue is about how we are unable to address those through the financial allocations that we have. And as Jackie has very politely said, in fact, I've just forgotten the polite form of words that you used there, Jackie, but we have a number of financial challenges. I think that was a different word you used, but it's clearly going to be really hard. So I think from what I took from what you said, Sandy, is that we would probably expect something to come back to us in March, which allows us and indeed the public to get a feeling for this is practically how we're going to bring together the financial allocation and our ambitions around actions against those 10 priorities. Is that fair? Is that where
Absolutely.
we're going?
Yeah.
Okay. So are there any other questions that people would like to make? Bearing in mind this is a report for noting. Okay. Thank you, Sandy. Very clear. Oh, I've got two people. First of all, I've got Trish Edney, who's deputising for Judy Robinson, but Trish, I'll let you introduce yourself and then I'll come to you, Chris.
I just wanted perhaps to say that this plan is really ambitious and ridiculous. Well, yes, over ambitious and ridiculous. And that perhaps option number one should be to give the NHS a bit of a break and a pat on the back if COVID levels had got low. To expect you to do all this is, well, it's pie in the sky. I'm sorry, I know I'm not supposed to be swearing or anything, but I think it is.
Thank you, Trish. And certainly in my book, pie in the sky isn't swearing. But right, Chris.
Yeah, I agree, it's quite aspirational, isn't it? But I was pleased to see that the 10 points are key things that we've identified in, our plans previously and current, and just also to hope that it's more than pie in the sky on the section 2.3 about population health and tackling inequalities and outcomes. The value for money, but the last one, the support for broader social and economic development, because without that wider context and the discussion we've just had about what we achieved through vaccination, that was about, particularly some of the wider population, but also in the context of that social and economic development and what we needed to put in place to make that work. So, yeah, I agree with Trish about the difficulty of achieving this, especially where we are with the pandemic at the moment. But I just wanted to acknowledge some of those outcomes are really key if we can make them meaningful and not just, talk at that level. More than aspirational, I hope.
Thank you, Chris. And again, I think one of the important things to recognise is that, Chris, you chair the Primary Care Commissioning Committee, and one of the many issues and challenges that we've discussed there has been the huge pressure that general practice and primary care is under at the moment. But Zach, again, if you could just introduce yourself, Zach. You might have done so, do it again.
I'm Zach McMurray, Medical Director at the CCG. I think the danger is with some of the other pressures that will be seen as pie in the sky. But who could argue that we don't want to deliver this? I think the problem is it's not going to be delivered in the current way. So the biggest elephant in the room for me, I mean, some of us have seen the elephant for many years. I think even the elephant blind, or those who choose to be elephant blind, can now see it, is the workforce crisis. And that's both health and social care. And I think that's why it appears a little bit pie in the sky, because if we don't solve that bit, then there's absolutely no chance of delivering any other stuff. So, and we're not going to solve that just by putting in more money, or by having more targets, or just by stamping our feet and saying we want it to be delivered. It's just not going to happen. I think we've demonstrated through the vaccine rollout what can be achieved, and can be achieved within an NHS in crisis. So it is achievable, but it needs a different approach. And that's back to the thing we talked about in Sheffield, and that a lot of that approach is about relationships and getting people on side and bringing in all the extended support that you can. So it's working across health, social care, bringing in the voluntary sector, bringing the population along with us. And it is achievable if we can do that. But I guess the question is whether we'll be given the freedom and the autonomy to do that. And I think that's going to be the big challenge as we move into a new system. So I think, Chris, I think, people are right when they say pie in the sky, because things seem so dire at the moment. But I would just say that, the vaccine rollout looked pie in the sky a few months ago, and we've achieved it. We have achieved it in spite of a system rather than probably supported by a system. But I think it's something that we've got to target. We've got to tackle the big issue. And the big issue at the moment is workforce. If we don't have the workforce, we won't deliver any of this. And I think we need an open and honest debate. And we also need to ask people, why are they retiring early? Why are they reducing their hours? And the bit that really worries me is, why are medical students who are training to be doctors talking about leaving the UK and working in other parts of the world? That is the bit I find most scary at the moment. And so it needs an open and honest discussion, a transparent debate about it. And I think unless we do that, I think it will be pie in the sky. I'd really like to hope it isn't.
Thank you, Zach. Now, I just want to reinforce this, and this is not for people here so much, but just for those members of the public who are watching this. When we're talking about the 10 priorities, these are not priorities that Sandy has come up with. This comes from the national guidance, and the discussion that we're having here is how we make we square the circle between the funding, once we know exactly what it is that's available, what we know about Sheffield, and how then that fits into these 10 priorities that we don't disagree with. But as Zach said, I mean, there's real issues about balance and nuance there. Sandy, I'll come to you, but first Ben, and then I'm going to let Sandy have the concluding comments, and then I'm going to move this on.
Yeah, just two short points. So just to add to Zach's point around workforce, I think often the thing that could be missed here is the reception and administrative teams that can just tee up our work really effectively. And whereas it takes a long time to train a doctor and a paramedic, in 3 months you can have people who are ordering the work and organizing the work really efficiently. And I think that's an undervalued, invested in kind of strategy of how we can manage things. And then there's just a bit of a subtlety that I just wanted to kind of point out that I've kind of mentioned in a previous meeting around COVID, point 2 COVID-19 vaccination program. I think that's both a priority but also a threat to the rest of it. And the subtlety is that it's not just about the funding, because it might be they can say, okay, here's all this money per jab, it's now funded. It's also about the way that the funding comes in, because if at the moment it's like, okay, we need loads of vaccines, we'll pay for it, who can do it? And then we scramble staff. We can't really employ anyone new because we don't know if this funding's predictable, if it's going to be ongoing. So and then you do your vaccines, you're exhausted, you've disrupted your systems, you're behind. The difference being, if it was like if there was a planned service that where the funding was kind of predictable, you could employ the staff for a service for a period of time, it's consistent, and then general practice could just concentrate on what it's used to do, instead of kind of constantly being distracted, never knowing, is this money going to be going on for long enough for us to employ some more staff, or should we just stretch the people that we've got? And nobody wants to employ somebody when the funding might only be for 2 months. So it's just about not making sure the vaccine program doesn't derail general practice by funding is one thing, but it's how the funding comes in, and doing it as a contract might be better than just like per jab.
Yeah, no, thank you, Ben. And I think there is while there's a tremendous amount to learn from the response that we've taken, we're also trying to build here for a sustainable health and care system, and that cannot be dependent on people's enthusiasm and principles alone. It's got and willingness to respond during times of crisis. Sandy, I'm going to give you the last word, and then I'm going to move on.
Thank you. I very much welcome and agree with the comments that have been made, and think that, in my view, a lot of those priorities is what we're actually already doing. I think, as Zach says, if we can have the freedom to prioritise what we can for Sheffield, and actually, I think, emphasise what we have been doing is working more collaboratively across Sheffield and across South Yorkshire as the ICS. So it's really embedding that transformational changes that we can do to meet those priorities. But I think one thing we can all agree on is that COVID has exacerbated health inequalities. And if we get to a point where the COVID levels are low, which is what the scenario this planning is based on, then actually we absolutely want to be prioritising and focusing on what COVID has caused in that respect, especially across Sheffield.
Okay, thank you very much. So I'd just like to thank Sandy for the report. I think it gives us a really good heads up for a further discussion when things we hope will be a bit clearer with regard to finance. I think we've agreed that that's probably likely. We hope that will happen in March. Okay. Now, I'd just like to, we've been joined by another governing body member, by Dr. Amir Afzal, who's come straight from a COVID clinic. So welcome, Amir. And I'm going to move us on now to the next item, which is the governing body assurance framework. Amir, I just need to tell you that you're upside down. So if you could just sort that out, that would be helpful, because it is a bit confusing. And you're upside down, mate. You need to right, because this meeting is in public, Amir. So right, and just recover from that. And the governing body assurance framework. Over to you, Kath.
Thank you. So that is quite off-putting. So thank you, Chair. So I'm Kath Tilney, the Associate Director of Corporate Services, and as Mark says, I'm here to talk to you about the governing body assurance framework, which we call the GBAF. And governing body members will be aware that the GBAF is the process by which the CCG ensures that we're managing our strategic risks and looks at that in detail. So it's helping make sure that you're assured that we're achieving our strategic objectives. So today I'm going to present you the Q2 review position, which due to timing of meetings is actually covering the period between August and October. And prior to governing body, this has been discussed in a lot of detail with the senior management team and the audit committee. When we spoke about this at the last governing body, when we were reviewing Q1, we had a really good discussion. And at that point, we were recognising how we've got a lot more higher scoring risks than is the normal state of affairs. And we agreed that we would, a number of actions were agreed across various discussions, but we wanted to make sure that we were happy that that those risks have been scored correctly. And you'll see in the paper, we've got a section on that. Really the high scoring risk is reflective of all the discussions we've just heard take place, reflecting the impact that the persistent high pressure has had on the health and the social care system due to the pandemic. I just wanted to highlight a couple of key points. So I mentioned we've had discussions at SMT, at the senior management team, audit committee and governing body during the Q1 review, and we also had feedback from internal audit. So a number of actions were agreed as a result of this. And when we took the Q2 information through to SMT, they agreed that we picked up the variety of actions that have come through that. We've got 4 risks that have reduced in score and 1 that's increased. The one that's increased is risk 5.1, and that's linked to staff anxiety and uncertainty, linked to the changes in the ICB that are coming, and also high levels of workload linked to this as well. There were 20 new actions added into the framework during this period, and we now have all overdue actions have been closed, which is brilliant because I don't think we've actually managed to achieve that for a little while. So we really tidied things up, and there are 28 actions remaining, which are not yet due for completion. At present, we've got 3 critical risks, and Sandy Brogan is the delightful owner of all 3 of those. So what I'm going to do just to finish off is just hand over to Sandy, and she's just going to go into a bit more detail around those to help sort of understand what's behind some of that. So Sandy, if I hand over to you, thank you.
Thanks, Kath. So as we go through the 3 risks that have been identified as critical, I think we need to recognise the discussions we've just had before, and basically that they're all aligned to the ongoing challenges of the COVID pandemic. So risk 1.4 is the risk that inequalities have worsened as a result of COVID-19 due to elective activity being paused and exacerbating those with long-term conditions. Risk 2.2, which is there is a risk that system-wide or specific provider capacity problems emerge in secondary and or primary care that hinder the recovery of service delivery post-COVID, as well as delivery of statutory requirements of the NHS Constitution, NHS long-term plan and our operational plan expectations. And risk 3.2, which is there is insufficient resilience in primary and community care, in particular GP practices, but also in the community pharmacy, care providers and the voluntary sector, that we are unable to expand capacity in primary and community care. So the rationale for all of these risks to be at a critical level recognise the impact COVID has had, especially on primary, secondary care and social care itself. And as we've seen in the planning guidance and guidance that was published for the second half of 21-22, there are national priorities to improve the waiting list and get back to restoring services. However, it has not been felt that we're in a position at the moment to really enable those plans to get us to that point, as we continue to see challenges both in workforce, COVID cases and demand, etc. At this present moment in time. So all 3 risks have identified controls and actions to mitigate against those risks. And we have stood up currently command and control situations both within the CCG and within the Sheffield system, as well as within South Yorkshire and Bassetlaw. But these 3 risks are very much identified as being critical and remain critical in the current situation. I wasn't going to go into more detail than that. I think the discussions that we've had already really do outline the reasons why, more than what I can justify, especially from the feedback that we've had from our GP colleagues. So if there's any other questions, then I'm sure myself, Kath or Zach possibly could even answer them.
Thank you, Sandy. And there's more detail in the report as well, because we've included those in the appendix. So I think that's all I was going to say. So it's really over to any questions.
Yeah, thank you very much. And I've already got a couple of people with their hands up, and I'll come to you very soon. I mean, the only other thing I'd say is that I think, again, I would say there's a related report, because the I think one of the things, Kath, in your next report that you're going to be talking about, you highlight some of the challenges we face with regard to data collection, and some of that impacts across is related to these risks, particularly I think the elective care one. I'll come to Lee first and then to Ben.
Hi, yes, Lee Salisbury, a GP in North Sheffield. Thanks, Kath and Sandy, for this report. It is, as ever, really helpful and, as ever, really sobering. And I suppose I just wanted to make an observation, really, from the ground. We talk about health inequalities, and the thing that have been making it worse in terms of COVID, and the things we've mentioned are, the delayed elective work and the exacerbation of long-term conditions, something that I've not really heard talked about much, but I'm noticing increasingly, certainly amongst the patient population where I work, is the impact of premature deaths. So we know that COVID had a disproportionate impact on populations with economic adversity. And we also know that in that population, people were disproportionately young to actually have COVID and also to die from it. And I'm recognising that a significant number of patients from the practice I work at are wage earners who've died. And it's a really simple thing, but I've not heard it talked about much. And that has an impact economically, but also personally and in terms of life chances for the children that are there. And I think the impact will be huge going forward. It isn't just about immediate health issues. People haven't got as much money as they have because the people who earn the money have died. And again, it's disproportionately affecting the poorest in our population. So we really, I suspect the fallout from this is going to be much bigger than we're even anticipating.
Okay, thanks. Can we get Ben's comment, and then we'll just come back and just reflect on what Lee said then.
Yeah, it's a kind of a general point that kind of covers quite a lot of the conversations that we have around it seems like a really big issue and a really big priority for both patients and for all of us is around access to general practice and staff resilience. And something that I've also noticed that it seems like it's very, very difficult to measure. And I wonder if the two may even be related, because when something is easy to measure, you can see it getting worse. It's easier to plan. It's easier to see if what you're doing is working and if it's not working. Whereas if I wonder whether or not so one of the questions is, what's the actual data that we use to know that we're really struggling? Because I wonder whether, I think data might actually be the thing that can help to drive the improvement. And I wonder if there's a relationship by the fact that we're struggling so much because it's so intangible and therefore hard to act on.
So there's two things there. I mean, I think we need to. I don't know if anyone wants to play in response to what Lee is saying, but it's unfortunate that Greg Fell, our Director of Public Health, has had to go, because I think one of the things, Lee, that you're talking about there really relates to the wider determinants of health and the impact there. And we started the meeting off with, and rightly so, recognising the work that we've done thus far and how we've pulled together. But what you're saying quite clearly is also actually the work's not going to end. We now need to think about some of the impacts there. And is the system, the place of Sheffield, one that's actually going to be able to pick up and continue to recognise and respond and support to people there? So I wonder whether it's appropriate to just to have an action point there. I think, Sandy, this might come your way, given your role with Lucy Ettridge in terms of supporting the health inequalities work that we're doing. And that we maybe put an action point in, which is to consider how we respond to the financial impact of in particular people who are wage earners who have sadly died during the course of this pandemic. Leslie, did you want to come in on this?
I did actually. So Leslie Smith, Accountable Officer, and it was really to add to Lee's point and to Ben's, so on inequalities and data. And I think there's something for me about predicting what's going to come in the next 12, 24 months. So thinking about Lee's point about the death of wage earners, I was also thinking about a perfect storm of factors that are happening at the moment, which are the end of furlough support, changes in welfare benefits to families, and equally significant increases in the cost of living in terms of buying food and heat and fuel. And if you think also of what's the impact of that going forward on family units and the life chances of our children. And therefore there's something, and Ben referenced the data, that how we can start to predict and take a more sort of measuring risk approach in terms of tackling inequalities as well going forward.
Okay, really helpful. And so we're picking up also on the data bit, which also I think part of the, what I take from Ben's point with regard to data is how do we retain an objective focus on this so that our actions are meaningful, and that is for looking forward. Sandy.
Yeah, I was just going to say that I'm more than happy to take an action to actually work with the Health Inequalities Group of the CCG, which is led by Lucy and myself, to actually look at refreshing our health inequalities plan based on the consequence of what's COVID has done on exacerbating health inequalities in Sheffield, and really look at this in areas that we might not have considered before, and one area what Lee has explained. So I think that we need to take that as an action and do that alongside the commissioning plan for 22-23.
Okay, thank you. And I noticed that Amir wants to make a contribution, but just before that, just to I'll wait. Amir, go ahead.
Right, I'll keep my video off, seeing as you find it so disconcerting, Mark. I'm sorry, I don't know what's happened with that. Just one kind of reflection and one possible action point. I did read a report somewhere that just narrowly looking at healthcare rather than the wider determinants, that the private sector has seen a huge boom. And I think that further kind of widens the health inequalities, because those who can afford to will bypass the long waits, the inevitable long waits that we now have in the NHS. My possible action point is that before the COVID clinic, I was in our PCN meeting, and we were discussing health inequalities, and part of the new additional roles monies designed to kind of correct some of that. And it seems a bit bitty, and I just wondered whether it would be possible to have over a citywide view rather than 15 individual views, so that we can actually do something meaningful instead of the usual kind of dementia or data, or we've looked at this little bit, or we've looked at that little bit. It was just a thought, really.
Thank you, Amir. So, did you introduce yourself, Amir?
I am sorry. Yeah, I'm Amir Afzal. I'm a GP in Central Sheffield.
Thank you. Okay, I'm just going to, I think we're coming to the end of this discussion of this report. I think what we've agreed is that we have a working group on inequalities, as Sandy has said, that both she and Lucy Ettridge commonly lead on, and that it feels that this is the issues that have been raised should be going there. I would just flag up and declare an interest as the chair of Citizens Advice Sheffield. One of the things that we are able to do is to capture, to spot trends earlier in terms of people coming to us with asking for support around things like indebtedness, for example, and access to welfare rights. So I think we're in a position in real time of being able to tell which way the trends are going, which could help us as a CCG in thinking about the economic impact of COVID and changes to things like, as Sandy said, or I think someone mentioned, when furlough goes, and the impact that has on people. So I think there's data there that we can be looking to use. I would just reinforce the point. What I take from what you said, Lee, is I think there's some broader population stuff that we can capture. There's a relatively small number of people be affected, thankfully, in terms of the scale of the city, with regard to the death of somebody who's a wage earner, but nonetheless we need to retain a focus on that because it's a huge impact on those families. So I think there's sort of two tensions that we can manage, but we can pick this up in the health inequalities work we're continuing to do in the CCG. Right, thank you very much for that. And it's still Kath Tilney, and we're now moving on to the item 11, paper F, the month 8 performance and delivery report.
Thank you, Chair. So as usual with this report, I'm going to assume that governing body members have read the paper, and then I'm going to highlight a couple of key points. There is a section around vaccine delivery, so I won't be highlighting that because I think we've covered that in quite a lot of detail already. So I'm going to jump that section. So I'm going to do it in a slightly different order than I normally do and start off with the staff temperature check, which is a monthly survey that we carry out with staff, and we have been doing this now for, well, it must be over a year. We started it near the beginning of the pandemic, and it's an opportunity for staff to tell us what's working well for them and if they've got any concerns or suggestions. And the reports, there's a summary of what's coming out of that in the paper, and we've changed the format a bit to give a bit more information on trends, and it includes an additional word cloud about how staff are feeling. Some of the most common themes that are coming from this is that there are many staff that are still enjoying working from home, and that's giving them a better work-life balance, but that's not the case for all staff, and some staff are finding this quite tough, and some are struggling with workload, and the particular theme that's coming out is uncertainty linked to the ICB changes that are coming. That's really come through quite strongly in this report. Actually, the following month, which we just see for December, it's coming through even stronger. So that's something that we are looking at, and we talked about, in fact, today at senior management team. There's quite a few forums where we discuss this information. We really build it into the structure and the ways of working. We have a temperature check group that meets to have a look at the initial information. Staff forum look at it, the wellbeing group do. Mental health first aiders looked at it yesterday, and deputy directors are discussing it on Monday, and SMT it's escalated there if we think there's something we need to escalate up. So it really is built into our way of working, and we're very proud of it. There's regular feedback at staff brief about the what it's saying and the what's happening around it. For example, we did have and we vary the questions. So we had a question probably about 2 months ago when we were opening the headquarters 722 up a bit more to people that were struggling working from home, and we got feedback on how they were finding that. It was really, really positive for so many people. And then when there was a national announcement that people need to stay working from home, I could feel those comments in my head at night thinking I can't let those people down. So we took that into account in our messaging on how we manage the message following the national announcement, and we kept it open to people that are really struggling because we felt that fitted in with the right way of working. And we had staff saying, they thanked us for that because they had not slept that night either, thinking I can't go into the office. So I think that's a really important part of how we work. The other area I wanted to highlight, which is what I normally start off with, is the Nhs Constitution Measures. And really this links back to everything we've been talking about earlier, because as you can see in the report, it's predominantly a sea of red. And we discussed this at the last governing body meeting, that this really is reflective of the situation and the high level of issues and the way that the system is very challenged at the moment. The position remains largely the same as it did last time. There's a couple of areas where we've had some improvement, but it has worsened in some areas as well. And I think one of the main examples of that is looking at demand on the 999 ambulance service and the impact on response times and handover times in A&E. The details in the report around the way the system's working to try and improve that performance and maximise what is possible with the capacity that we have. We have a new section in the report, which is around the system priorities and operational planning that really I'm going to do a double act with Sandy again. So this is an area that Sandy's worked with the performance team to bring in. So I'll hand over to her and she can explain what that bit's about. Thank you, Sandy.
Thanks, Kath. I'm not going to take the credit for this because it was certainly an idea that Anthea had and we spoke about after the last governing body. The second half of the planning requirement for 21-22 detailed a number of targets that were deemed a priority, and these were in relation to the elective list size, the waiting list and backlog, which included eliminating 104-week waiters, reducing the 52-week waiters and returning cancer waiting to their standards by the end of 21-22. The details in the table in this section details the actual figures up to October 21 and the plans that were submitted with the forecast trajectories. I have to go back to saying that the scenario by which the plans were based on was that COVID returned to low levels. We're in January and that hasn't happened. And obviously the targets that were produced has not been met with the actual figures. So it's not transpired to what the assumptions that were made at the levels of COVID that we've seen. However, I feel that actually if this is what we're submitting as part of the planning, we should actually demonstrate where the actuals are against the forecast within the plan submissions and monitor this both in governing body, but also we're monitoring this as part of the South Yorkshire and Bassett law system as well to see what can be done whilst we're in high, challenging, pressured situation with COVID, but recognising the backlogs and waiting lists are getting worse.
Okay. Thank you. So have I got any questions for points of clarification or comments? And I've got Jackie, and then I'll take Judy and then Lee.
I suppose this is just a comment around the data flow. So I know, Kath, in the report, the routine monitoring of some of the data through our normal contract monitoring mechanisms has stopped. And one of the items we've put in the report is we're not getting data on delayed discharges. However, we are getting those through alternative routes. I'm just wondering whether we should look to explore whether we can capture the data that isn't routinely provided, but we are getting through different routes, because there probably is a bit more intelligence we can provide there.
Okay, can we just hang on responding there, either Kath or Sandy, and we'll just hear what Judy and Lee have to say. Judy?
My comments were around the ambulance response times and appreciating, that we know kind of why and what's happening in terms of the impact. From a policy and an outcome perspective, clearly we want to know that there's been no harm. So I think one of the things that we need to do is take to the next quality committee, have a report which tells us what's happening and what NWAS is doing in terms of particularly sort of looking into those response times, 11 minutes compared to 7 minutes for category 1, those 4 minutes can make a huge difference. So I think we, just to say that to governing body that we will be looking at that. One of our team attends the regular meeting where it's quality is looked at the ambulance service, but we need to pay some interest to that, I think.
Okay, thank you. And Lee.
Yes, thank you. Really, it's a similar point to the point that Judy was making. I look at this sea of red and it baffles me when I hear news reports that we've weathered the storm, we've done really well managing this pandemic, and the NHS is surviving. Do you know, it's by the skin of our teeth, really. And I think it isn't clear what the cost has been to other health issues. And I think it's really, really important that we do all that we can to try and find out what that detail tells us, particularly with regards to the ambulance times, Judy. There was a report on Look North last night saying that there's no longer routine transport for many patients to outpatient appointments because they haven't got the staff to do it. You know, they've got to support the emergency response. That is a huge impact. That is not the NHS coping well. It's the NHS under pressure. If you talk to anyone in the wards, in A&E, you know, whether it's staff or patients, I have lots of patients saying they won't go to A&E even when they need to. Even today, I had a mother of a child, she wouldn't take her child to A&E, even though it was clearly indicated, because she'd already been there last night, waited 6 hours and couldn't bear it anymore because her child couldn't cope. You know, it is not coping. And I think that's really important that we get that message fed up the system as well as we can. Having said that, there are 2 green pockets in that table, and I do, you know, really welcome it's remaining green for the time to treatment for cancer diagnosis. So that's really important. And also, probably for the first time in a long time, the IAPT targets are being met as well. And, you know, notwithstanding that we're not meeting the access, which we talk about most months, when people are being seen, they're obviously having an improved experience. So that's welcome.
Okay, thank you. And before I go back, let's just hear from Nikki. Again, Nikki, could you just say who you are, please?
Yes, Nikki Bates, the GP representative on governing body. I wanted to just talk about the ambulances again, like Lee and Judy. It seems from information from other areas that some places are doing better than others on managing to get patients out of ambulances and into an appropriate clinical setting. And I was wondering if Sheffield teaching hospitals were prioritising that at all, and if not, why not? So that was my point about ambulances, and I agree with everything else that's been said.
Okay, thank you. And I'm just going to keep pushing back Sandy and Kath, because let's just get some responses, and then if you want to make some concluding comments. So Anthea.
Thank you. I'm Anthea Morris. I'm the lay member for governance at the CCG. I'd just like to thank Sandy for listening to me, first of all, and then taking my points on views on those last charts of the paper, just showing sort of the line of where we think things to be. And that was in response, as Lee said, it's a sea of red out there. And once you sort of hit red, how do we know if the red's getting better or worse? And I think it's realistic to, especially now with Omicron, that we're still going to be red for a period of time. I will let others put in what they think that period of time might be. But I think it's important that we know what our recovery is, because you can't get redder than red. But how do we know we're still on track to reducing that, to coming back? And what is our time frame for business as new normal, perhaps I should call it. And I think that's probably measured in years, not months.
Yeah.
But thank you for doing it and for starting that. And I hope that can carry forward for next year.
Okay, so I'm going to bring this item to a conclusion. But before I do that, and I think there are three issues really. One is a general one, which is this item in particular is a real reality check on some of the other things that we've been talking about around whether that's NHS England priorities or financial allocations and so forth, because this is telling us this is how it is at the moment. Within that, there's a point about delayed transfer of care, and some of the how do we keep a handle on some of the data with regard to that. And then secondly, there was a point about ambulance response times, but also a suggested action point with regard to taking a more detailed discussion to Quality Assurance Committee. And then the only other thing I would say, and not wanting to put you on the spot, Trish, but I think one of the issues for health commissioning organisations is, like the Clinical Commissioning Group, is while we can feed, and we will be through our performance data, be feeding back reality check back up the hierarchy and up the chain. Obviously, independent organisations like Health Watch Sheffield will also be concerned about some of these things, and I'm sure we'll be thinking about whether there are stories that it needs to be capturing over the next few months that actually might reflect in a slightly different way, in an independent way, some of the issues that people are facing in the city. And if you may want to say something, Trish, but you don't have to. And I'm looking that, yeah. Okay.
I think there is so much understanding of the terrible position that the NHS is in, but it's understanding until it's actually hitting you. Everybody can say the right words, that they know that the NHS is under strain, but then when it's affecting you, it becomes all encompassing, and this is where we get the crisis points. I think Lee's story of a lot of people not wanting to go to A&E is still true. But it's people all react differently, and there are going to be stories, and it's actually going to take a long time for people's memory of all this to go. And even in a year's time or 2 years' time, when you're actually managing your access really well, I don't know how, but you are, or you could be, people will still remember that you can't get an appointment at the GP and you can't get an ambulance, and that the wait in A&E is terrible, because people's memories are really quite long about disasters.
Thank you.
We'll keep on our reports.
Yes, good. Now, Alan, have you got a quick point to make before I'm then going to come back to Kath and Sandy, who've been listening to this conversation.
Yeah, so I think it is a quick point, and I think it's significant, Mark, particularly for the discussion regarding Yorkshire ambulance services and quality of services. We have to remember here as a governing body, and remind our lay members of our Quality Assurance Committee, it's quite a good action that Judy has suggested, because Sheffield CCG has the responsibility for quality for all areas across Yorkshire. For Yorkshire Ambulance Service, we manage, as part of the contract, the quality assurance processes. So while we're here focusing on Sheffield, our responsibility is much wider than Sheffield. It is the whole of Yorkshire on our quality assurance processes. So I would support Judy's action in what was suggested, Chair.
Thank you. Okay, so you've listened to the discussion prompted by the report. Sandy and Kath, are there any responses you'd like to make?
Want me to go first, Kath? Yeah, so all I was going to say was absolutely welcome the opportunity to go to QAC, really. Discharges and ambulance times, it's part of the daily stroke weekly conversations that we have with STH as part of the silver and gold command structure in facing what we are facing at the moment. So very much welcome that opportunity. We do have live data that we work to, and like I said, action plans, and these feed up to NHS England, and discharges is very much on the peripheral quite a lot at the moment. So it'd be very good to go through that.
Thank you. Kath?
Yeah, so delayed discharge data, I think I have tried to get that in. For some reason that never happened, but I will make sure it happens in future. So that's helpful. Thank you, Jackie. I think it kind of links back to something that Ben said earlier around the primary care data as well. It is very secondary care focused, this, and that's part of the national information. So I do think as we move forward, having performance information related to primary care would actually be really useful as well. But we're not quite, it's just not very easy at the moment, but that does need to be an aspiration for us, so that we're seeing the whole system picture. So that's something we're very aware of and we are working to.
Okay, thank you. So we're noting the report and accepting it, and but also we've agreed a further action, which is to take the delayed transfer of care issues around the ambulance service to Quality Assurance Committee. Okay, fine. So we now move on, Alan, you're back to item 12, paper G, Patient Safety, Quality and Experience Report.
Yep, Thank you, Chair. The paper presented provides an overview of areas of activity over the previous month relating to patient safety, quality and experience. I would like to note to governing body that, you know, as the common theme is that we're in unprecedented times in responding to COVID-19, and this continues to massively impact on all public and voluntary sectors. Mainly for the CCG, this has included the quality team workforce, which has been supporting the primary care vaccination programme and supporting wider engagement with other agencies. But I'm pleased to say that so far we've been able to maintain all our main areas of assurance processes so far. I will highlight the key elements of the report, Chair, and happy to take any questions at the end. I'm going to start with Care Quality Commission reports, and so therefore the current positions within relation to our and relates back to some of the risks that we've seen highlighted in our governing body GBAF report is that which remains high, and that is related to some of our acute providers that have had recent CQC inspections, including Sheffield Health and Social Care Trust, which is a while ago now, but have subsequently continued to make good improvements in their action reports. We oversee through a contract quality mechanism, but also a joint mechanism with CQC and NHS England. We still await a subsequent follow-up visit recently undertaken at the Care Trust. However, just to governing body, we're not anticipating that follow-up visit will have an effect on the overall rating for the trust at this point. That will come later in the future after continued improvements are made. Moving on to Sheffield teaching hospitals. Again, we had a move in maternity services from excellent to inadequate on previous CQC oversight and inspections, and we still await a full inspection report that was undertaken previous months now. I believe back in September and October. We are not anticipated to receive a final report within relation to the full inspection until now towards the end of January. It was anticipated that it was going to be the beginning of January, but as with all organisations, staff have been allocated to the vaccination programme, so there is some delays in reports coming out from CQC, but we continue to manage the maternity quality element through a joint board with CQC and NHS England, and we also continue to monitor progress through the CCG quality oversight groups. Sheffield Children's Hospital received their quality report, their CQC report, which was an overall good. Just to note to governing body, there were some caveats to the overall report for particularly around CAM services and some improvements in CAM services which have commenced. Again, these are monitored all through our quality monitoring processes. Primary care at the moment are all rated at least good, with one excellent that remains in place, which is good. However, we continue to be informed by CQC that regulatory visits will commence, but they continue to be pushed back again because of the COVID-19 response that primary care is involved in. But we're anticipating that they will commence shortly. As part of the CCG's responsible accountability, we manage all serious incidents that, as I've just described, from all providers that we commission services with, but take lead responsibility for Yorkshire Ambulance Service also. All incidents are monitored within the national framework, and it's fair to say that all NHS providers are required to undertake serious incident events, whether that's primary care, nursing homes, acute providers, all have the same accountability and responsibility. So some work will progress over the next 12 months within relation to the independent sector, because there will be changes to the serious incident process anticipated now from the 1st of July with the white paper and its assent. There is just one incident that we have returned for further information to one of our providers this month, and that is solely because there's another NHS organisation that obviously needs to undertake some additional learning as part of the incident. So we're just working with the two providers at the moment to get approval of a final serious incident report. Infection control within the report, as you can imagine, a very busy team over the past 12 months, 2 years. The infection control team have done a fantastic job in supporting all providers within relation to infection control and outbreak management, particularly around COVID-19. Other infection control issues such as C. difficile have reduced actually, but are still apparent, and novavirus still continue, E. coli still continue, and we just started E. coli monitoring again. So, but they're not as prevalent as they were previously to COVID-19, which actually goes to show that some of the messages and the usage of personal protective equipment, PPE, is absolutely supporting better infection control measures across our providers. General practice, again, at the moment, as I've said, all remain good. We've discussed in, I think, every paper at governing body here about the workforce pressures and the pressure that primary care is under, and again, I think it is worth noting from a quality perspective that we continue to support practices that are challenged. All are challenged, but some are challenged more than others in our support to maintain their services, along with oversight of quality from these providers. Care homes. So care homes, there's continued oversight and scrutiny by both the CCG and the local authority. And again, I want to dedicate their work and support that they've provided to their residents over the past 2 years. It's been a huge challenge for them also, along with all sectors of the health and social care workforce is a challenge, and particularly we have seen, unfortunately, for care homes that have had really serious, significant workforce challenges. We've managed to maintain, and again, we're in probably a critical few weeks over the next few weeks in order to maintain services as they are within relation to the rise in infections. Our service of continuing healthcare and children's continuing healthcare have continued again. We personally have seen some significant workforce challenges, and again, I'm proud say that the team have adapted to be able to continue to provide assessment and funding decisions to support discharge, to prevent admissions, and to ensure that our population that do have care packages are being overseen. Again, it's a very intensive and quality, a very intensive process and quality oversight that's required for these vulnerable individuals, and we're maintaining those against significant challenges at the moment. There is a section on COVID-14. I've moved from COVID-14 from 19. It's nothing different. Apologies. It was a mistake. Page 14 of the report. Highlights a point in time of our vaccination programme, and we heard our Director of Public Health raise around we've still got 100,000 plus. I think actually me and Kath have seen some data today that might just be under 100,000. So we're still around the 100,000. We still need to work from both a quality and supportive perspective into communities to raise these. And just to note to governing body, we may be coming to a supermarket near you to deliver some vaccines. So those are additional plans to try and engage with the population, and we continue with the evergreen offer of the first, second, and supportive vaccines from different services. But I think again, going back to Ben's point, from a quality delivery perspective, we need to focus on what is the long-term plan for delivery of all vaccines, along with the COVID vaccine as well. Happy to take any questions, Chair.
Thanks, Alan. I'm looking around and I can't see anyone raising any issues. There's an issue that I just like to flag up. One of the areas that you didn't touch on. I think that from my reading of the data, and I'm not looking for a long explanation here, but I am interested in where are we picking this up, who's got an eye on it, is the health checks for people with severe mental health problems and also for people with learning disabilities. In both cases, from looking at the data, it does seem that we still, at best, are sort of, well, we're still not even performing as the best place in South Yorkshire, and certainly not in terms of the northeastern Yorkshire. So I'm not looking for a detailed explanation, but I am looking for assurance about where we pick this up within our committee and governance structures. I mean, I know that we've got good people in this clinical commissioning group who are working on this, but it does feel like we still have some way to go here. And it feels like it maybe crosses at least a couple of areas, because I would have thought the Primary Care Commissioning Committee has an interest in this as much as maybe the governing body as a whole. So can I just let you mull on that, Alan?
Well, I can absolutely answer straight away for you, Chair. Okay. So I suppose in part, the answer is that this is monitored through the Quality Assurance Committee, and may have not made it to actually over the over report, but actions and issues raised both on mental illness and learning disability health checks are documented in usual noted quack papers that again that come as noted. You don't have those at this meeting or in our private session next, and that's because we didn't have a quality assurance committee last month. But you will probably I will ensure that some of that information flows through next time, Mark.
Thank you, because I suppose the bit, and we could pick this up, and I noticed that my good colleague Judy is nodding there as the chair of the Quality Assurance Committee, but this might have been an oversight on my part, but I think there's a relationship. My question is do we pick up issues to do with this in, for example, the GBAF as an area of significant concern? But that's something that we can pick up when it comes to Quality Assurance Committee. So I have now got two people raising their hands. So Lisa, we haven't heard from you yet, so you'll need to say who you are, but you can go first.
Okay, thank you, Mark. I'm Lisa Phillip, one of the GPs on governing body and a GP in North Sheffield. And I think my point was about the health checks for severe mental illness and learning difficulties. And I think looking at the numbers, they are quite shocking, but I'm not surprised because as a GP, I know how much we struggle to get these done. So I just wanted to say that looking through the report, I really welcome the steps that you put into place to try and help with those. We've tried to stretch our already overstretched systems to try and do these. So having additional resources like the healthcare assistants and the primary care Sheffield service will really help. And I think also working with community groups like Mind, MenCap and Disability Sheffield will also help. And I think that just is in keeping with the direction of travel of the CCG at the moment, because these community groups find it easier to engage with some of these people we may find quite difficult. And I think it can only help and be a really positive step. So thank you for the report. It's kind of an eye-opener, but it's great that you have a plan in place to help out with that. And I really welcome it.
Thank you, Lisa. And I'll come to Judy and then Ben.
So before you said, Mark, about the health checks and whatever, that's why I'd raised my hand, was to bring some attention to this. For me, I think part of the discussion that we had earlier when Lee started us off thinking about people perhaps not, patients, our population not wanting to attend both the GP practice and secondary care. For people with a disability and with mental health needs, we know that they will often access less often for a variety of reasons, but have more health needs. And I think this, as you said, Lisa, welcome some of the initiatives that are already happening or about to come in train, but I think potentially there's more that we can do. So again, I think this is something both for perhaps the Health Inequalities Group to have a focus on in line with the previous action that's been agreed, but also the Quality Committee. And for example, we need to ask some really quite respectfully challenging questions around the fact that the LEDA annual report in 2018 identified and was supported by the Department of Health that people with a learning disability and 2 or more long-term health conditions should have a coordinator in place. And are we assured that that's the case in Sheffield? Do people have those coordinators in place? And we know that the annual health checks, for good reason, due to COVID, have not necessarily been able to be undertaken as they would have been, or offered as they would have been. And we also know that people are still quite suspicious and not always understanding the real value of having that health check. So I think it's an action really, again, from my point of view as Quack Chair, for us to look at this.
Thank you, Judy. So we've got a, we've now got, I thought your hand was up, Trish, but it seems to have gone down, but which is fine. But I'm going to go with Ben and then Amir.
Yes, I'm Dr. Alan, a GP board member. You can start skipping me out, Mark, because I've had a few questions now, so feel free to prioritise other people going forward. It was just a subtle thing around the vaccine target. So from a public health perspective, we were probably presumably aiming at 100% vaccination, get those with 100,000 vaccinated. But from a personalised care perspective, our aim should be to get 100% of people to have an informed choice. And the problem is, I don't know how you measure that, because I know that in QOF, I'm quite proud of the people who we exclude, because that's work done. That's that's kind of personalized care, shared decision making. They don't want a statin, for example. I don't see that with the vaccines. And the argument for older people is very, very clear in terms of the evidence. The younger you get, the weaker the argument for vaccination comes, and I think that's why some people are opting out. And I don't know quite, as it has a system, how you allow for that and class that as work done. That person is made an informed decision, but I don't know if there's any chance of that being something that we could be aiming at 100% personalized, informed decisions rather than just jab in.
Right, thanks, Ben. You've just made everything really complicated, I think, for us here to think about that. And I'm suggesting that it's a very fair point, but I don't think it's one that we can get into debating here. But I mean, it is a useful. I mean, it's a perfectly fair point around issues around informed choice. So I'm going to come to Amir, and then Trish has got her hand up. So after Amir, Trish is going to come back in, and then we're going to come back to Alan for some reflections on what you've heard so far. Amir.
Oh, thank you. Again, just picking up the vaccination and building slightly on what Ben has said, but I think it's great that we've got capacity, and I think it's great that we've got a variety of places to be able to provide the vaccinations. However, I no longer feel that capacity is the main issue, to be honest. I think the issue now is the hard to convince or hard to get people to vaccinate. And that's complicated by several factors, partly because of the people's choice not to. And I mean, if I use Ben's definition, I think we've gone over 200%, never mind 100%, because the number of times that we've phoned people, we've employed somebody for the last 4 weeks at my practice purely for 4 hours a day just to phone people off the list. And if they don't outrightly decline, they get a phone again and again, hence the percentage. So I just wonder whether perhaps the capacity side of things should be re-looked at again, and a system provided whereby we can almost do opportunistic vaccinating, which always works better when you get down the cohorts to the last, 10 or 15%. And secondly, I think coming down to the level of general practice, particularly old dinosaurs like me who have been there for over a quarter of a century, and having personal relationships is also quite relevant with that particular group of people. The people who were going to get vaccinated have already done so. I mean, they've come 40 miles away because, for whatever reason. Okay. And again, like Ben, I really do struggle. I give my opinion in a very factual way. Because my consultation style is fairly informal, I informally tell people what I think, but ultimately the choice at this point in time has to be left to the patients.
Okay.
And people.
Right, and I think, both what you and Ben are both saying, or one of the things I think you're both saying is, look, this in the society that we live in, general practice and health services can do their best to offer and negotiate, but actually they can't force people to take vaccines. And I think we're sort of maybe starting to get into that territory with some of the remainder of the population who've not been vaccinated. Trish, and then I thought I was doing well for time, but I am very keen to bring this item to a conclusion because we've still got a couple of items to go in this public part of the meeting. Trish.
Thank you. Very, very briefly, it's just on the health checks that I gather we're going to look at these in other committees more closely, but actually having the numbers would be much more useful than percentages, because I gather, I don't know whether all the areas of Sheffield have got the same numbers of patients affected, and their performance may be completely different if you actually look at the numbers that they're managing to do. But it just percentages doesn't really help all the time.
Okay, so thank you, Trish. I think that is a really useful comment. I saw Alan nodding, and I think given what we know with regard to the incidence of severe mental illness and indeed learning disability, I think we might expect that some parts of the city will have a greater proportion of people who have one of those conditions. So I think you're quite right. Having a feeling for numbers, maybe by primary care network, would be useful. So Alan, are there any thoughts that you wish to, things that you wish to respond to briefly?
I can talk about COVID sit here all the evening, Chair. I suppose, I'm just reflecting the main parts of the discussion, while obviously the health checks, along with other primary care service deliveries, to support quality assurance, is something that we need to be mindful against the COVID vaccination and the call to arms that continues to come back to primary care to deliver, and what that affects. So we do have to be mindful around all primary care quality to deliver its services. The point around working on 100% percentage is that the percentage 4 or 5 months ago, Ben, of we worked on 85% to achieve 85%. So the 100,000 has stayed static. The 100 to 120,000 has stayed static, but that's because every time we go towards reducing that, another group gets added. So remember, the 100,000 now includes all above 12-year-olds in Sheffield, whereas a few months ago it would have been above 18. So while it appears in our figures to remain static, actually it's reducing in the background. Absolutely agree with Amir. I suppose one thing probably to watch out for, and I can discuss a little bit later in our private, I suppose private governing body, is around what is next. Is passports going to be a thing? Because if the massive surge in boosters was,
I don't think we don't need to go into a great discussion.
No, I don't. But I'm trying to just reflect, Chair, that the booster programme that's affected primary care in its delivery is about increasing delivery for a short period of time. What is the next bit where primary care will be asked to again step up? Is that because a vast majority of our population that haven't had boosters will require boosters to have a COVID passport? So we'll get another influx, Amir, of patients that are coming forward where services will need to step up.
Okay, thank you. So I think the key, I've just lost track of my notes. Yes, we've coming out of this discussion, I think the key bit is we've agreed, I think this was, we have agreed, looking at, we've agreed that we're going to take, I think the key bit is taking this to QAC with regard to mental health and learning disability. I think that's the main sort of action point. We note the papers, and we also note there's as is quite clearly the case, and I think Alan was sort of summarising that, is we need to ensure that we all understand what the vaccine take-up statistics actually mean, because the pitch is changing all the time in terms of who is included, and that helps us understand that, but it also helps the public understand how we're doing. Okay, thank you for that. I think, again, really useful, comprehensive description of the challenges and how we're responding to those that we're facing with regard to safety, quality and experience. So the next paper is paper 13, item 13, paper H. Brian would have been presenting this. Who's going to take us, just give us a heads up? Lucy. Are there particular things you'd like to draw our attention to here?
Yeah, okay, I'll just draw out probably 2 or 3, if that's okay.
Mm-hmm.
Hi everyone, I'm Lucy Ettridge. I'm the Deputy Director of Communications and Engagement and Equality. And this report actually is a high-level overview of the last 6 months' work of the team. And the report was actually written by the team and not me. So for communications, it shows that our increasing reach via social media and the media continues. We've had some really good success, including a front page on the vaccines just before Christmas. We've had great relationships with the GPs who are really actively involved in a lot of that media. And we've also started off this year's social marketing campaign on urgent care, and that's going really well. Drawing attention to engagement. So majority of a lot of the engagement we're really proud of that's in this report is summarises the work with the voluntary community sector to encourage uptake on vaccines. That approach has actually been evaluated and went to speak in December. We worked with Greg and his team and voluntary community sector people internally, and it was really, really well received. And it's something that we want to build on. And actually I was really pleased when Greg said that actually we need to scale that up in the future. We need a permanent shift in how we engage the population by the voluntary community sector. So that is something we're looking at in this year as part of our draft model for engagement as part of Team Sheffield. We're working on that. Other things that we're going to work on in the next quarter are a really, really exciting project on building 5 new health hubs in the city in 3 most deprived primary care networks. So that will involve lots of engagement, lots of consultation and lots of communications. And we'll be testing the model of funding the voluntary community sector even more by asking them to carry out lots of engagement for us on 3 or 4 areas over the next 3 or 4 months, including boosters, commissioning intentions, phlebotomy, neurodevelopment, and also primary care estates. So I think I'll leave it there, but I'm happy to take any questions.
Yeah, thanks, Lucy. I mean, I think it's important. I think it may have come, I'm sure it will have come to governing body in the past, but this is a £32 million capital investment programme that we'll be consulting communities on, which has a huge potential for really improving the quality of buildings in some of the more deprived parts of the city. But we understand and are committed to really trying to, in short time frame, which is not of our choosing, but we're committed to really trying to hear the views of all stakeholders from within those areas, and in particular the public who live there and use those services. Jackie.
Yeah, and just building on from that, because I know we've done a lot of the updates through the primary care committee, but probably less of a briefing back to governing body. So we'll think about how we bring some of that update back as that work develops. But just to note, we finally got Treasury approval. We're just waiting for the letter for release of the funding, which has been a mammoth effort, but allows us to really engage on something credible now. So it's really fantastic news for Sheffield, but it's important that we get that model right for our populations.
Yes, and if this hasn't sort of formally come here, and I'm sure we'll be talking about this in more detail at future governing bodies, but I think we should recognise and thank the work, not just certainly of people in the clinical commissioning group, but we've done this very much in partnership with the local authority, and I'm excited by the way in which we also now have a steering group looking at communication and engagement that includes members of the voluntary and community sector and Health Watch Sheffield. Chris.
Yes, I the PCC chair, so in case you've got Chris Neal, the LA member on the governing body, just wanted to echo a bit what Jackie was saying. It's a significant investment and quite complicated, and the company, which the name I've forgotten, which isn't good, has done an excellent job along with our key officers in the CCG at moving this forward, because it'll make a huge difference to what we've got in Sheffield. And we're at a key point now of making sure that the consultations with the community, with the patients are in place so that it reflects issues, in terms of access, in terms of any other issues to do with their services and what will be available. So yeah, it's quite key that we get this right, but as Jackie was saying, we want to do this in a proactive way with key people that work with the community. So I'm sure that we'll get this much better than it is already with that consultation. It's really a massive piece of work. And the Primary Care Commissioning Committee have considered it at length at each stage. So it's great news that it's been confirmed, the funding of it. So it might go down at the last minute, but it's good.
Thank you. Right. So what I'd this is our last paper, which is to consider and accept, and I'm assuming that we accept this paper. And we're now on to the accountable officer updates. And I think this is possibly the first time that we can hear from our accountable officer, Leslie Smith. But before I let Leslie speak, I'll just say that what a journey we've been on with this governing body, from hearing about some of the hard work that we've done in terms of addressing the challenges around the pandemic, through to some of the continuing performance challenges that have emerged because of that, through to coming to a good news story about some significant investment into the city. So Leslie, I'm sure, is going to match this by talking to us now about taking us on her journey and telling us about updating us on integrating care. Over to you, Leslie. If you could just introduce yourself first, please.
Thank you, Chair. Leslie Smith, Accountable Officer. So there's really one key thing for me to pick out today for governing body and for members of the public in relation to the journey of integrated care. And that is the delay in the target start date for the Integrated Care Board. So that has moved from the 1st of April to the 1st of July, so a 3-month delay. I think that's important to note because it will mean the continuance of the CCG with its statutory accountabilities in terms of planning and commissioning healthcare for the people of Sheffield going into the 22-23 year. I think the positive from that will be that we've got an extra 3 months to continue to build on our joint arrangements with local authority partners and to embed and pilot our place-based working arrangements going forward. So those are the positives. But I think equally we should recognise some of the downside of that, and it's already come up when we were looking at the temperature check, is the uncertainty for staff, whether it's real or perceived. We are seeing some anxiety in our staff groups about certainty around what does the future mean. They've probably been in that space going back to January 2021. And that's just a long time not to be clear on what those future arrangements mean. So I think it's just worthwhile governing body being cited in that, and the extension in relation to the target date for the establishment of the ICB. And I just wanted to check though on that whether, and it's probably neatly passes over, I thought Kath was before me on the due diligence and the close down of the CCG and she'd been missed, but I see that she hasn't. She's actually after me. So it probably neatly passes over to Kath now just to pick up on any key things from the close down report.
Thank you, Leslie. And I just wonder whether we should move straight on then to item 15, and that's paper I, the close down report. And then if there's any comments that people would like to make with regard to both what you've just told us there, which is really, again, it is what it is. We hope they don't hit us with another extension, but we can pick that up after Kath has just given us some highlights on the close down report. Kath.
Thank you, Mark. So yes, this paper really just summarises all that we're doing around close down due diligence, and it's there to provide assurance to governing body that we're managing the process in an appropriate way. Sheffield CCG remains accountable for delivery of statutory functions until the ICB is in place, and we also are responsible for ensuring due diligence is undertaken as we transfer our people, property and liabilities through to the new organisation. There's the process that there's a paper in Appendix A, there's a paper that's written as part of the ICS, South Yorkshire and Bassetlaw Joint Committee of Clinical Commissioning Groups, and they have an update paper, so we've included that for information as well because that summarises things very well. And then the paper that I've written really is about what we're doing in Sheffield CCG, joining with our other partners. This is led by governance leads across South Yorkshire. Nationally, they provided what's called the due diligence checklist, which is quite a big spreadsheet with lots of actions, and it's described as a practical tool for CCGs. There's a lot of actions in it. We don't have to report on all those actions anywhere. It's for use within our own organisations, and it is actually quite helpful. It's made us think of things that maybe we wouldn't have done. Some things we think, well, they're not so important. We've added some of our own in, and then we've compared that across with our South Yorkshire partners to make sure we're all on the same page. We have within the CCG an ICS transition group, and that includes the senior leads that are representatives on all the South Yorkshire change and transition working groups. And it's a sort of semi-formal, informal meeting where we can catch up with each other and make sure that we're picking up any concerns and keeping up to date on progress. As at 21st of December, I don't think I've got written down here how many are on the list. It probably says it in the main report, but there's a lot on the list, 93% of which were either green or amber as at the 21st of December. And really, you know, those are one, we've not done them all, but we know we can do them, or they're business as usual and they're just happening, and that ticks the box. We had 12 that we've called high amber, and we've created an extra colour, and those are ones where they feel that there's a bit of risk associated with it, but we're not too worried about it. There's only really one that we're counting as red, and that's one that's linked to the differences in commissioning, well, consolidating differences in commissioning policies across South Yorkshire. And there is a lot of similarity in our policies, but there are some differences. For example, in the IVF offer, and Barnsley has a Get Fit First policy that's different from the approach that some of the others take. It appears from what's written in the due diligence spreadsheet and that there will be a need to consolidate these. It's not going to happen before we turn into ICB. There's a long proper process that has to be followed in order to have one policy, and obviously public consultation would be needed, and lots of discussions would need to take place to make sure we get there. So we're in the process of seeking legal advice about what the implications are for that, and what a sensible proportionate plan would be as we move into the ICB in order to achieve that consolidation.
Okay, thank you, Kat. Sorry.
Yeah, so the last one last thing, sorry Mark, one last thing was just the delay. So there's a national timetable that we're following. Obviously that's shifted. We should be hearing something tomorrow, I think I've heard, about what the new timetable will be. So then we'll have to rework all our plans with sign off at governing body, because there's a whole sign off process with audit committee and AO and governing body. So once we get the timetable, we can then let governing body know what that process will be.
Thank you. And that would relate to when we look at the timetable, which is at the very end of the report, not your report, but the one that comes from the ICS. There's a timetable there which finishes in March, and presumably that's one of the things that
absolutely,
yeah,
it's all the timing of the reports before the change.
Okay, and I think one of the things, and that a number of people obviously like Kath, but other directors in the organisation are doing is having to look two ways, which is key, is actually continue to maintain our existing systems, but at the same time also engaging with this process of transition. And that's something that, so that means that a number of committees, and I would flag up the one of the ones that I chair, which is the remuneration committee, is increasingly focused on this transition period, as well as looking at existing work that's happening. Now I've got three people. I didn't keep an eye on who put their hands up first, but I'm going to go Anthea, Jackie, Lisa.
Thank you, Mark. My question is, without expressing an opinion or desire one way or the other, but from a pragmatic point of view, do we know if July is final or might it slip further? I sort of feel that we're going to be, we're not in limbo, but we're sort of entering limbo. And now we've just extended limbo, and given all that we've said about workforce uncertainties, the pressure on the workforce, and then the pressure on our own CCG team about the uncertainty of those jobs for 15 months. We're extending it 3 months. Do we know if that's absolutely it? And I know we don't know because it's a political process, but what's sort of the view on that? And should we hope for July and plan for whenever?
Okay, thanks, Anthea. So I'm actually going to leave Jackie until the end because Jackie tends to know the answers to everything. So I'm going to come to Lisa next.
Thank you, Mark. I'm Lisa Phillip, I'm GP on the governing body. So just thank you, Kath, for you and your team and all the work that you've done on this. I know that you've just kept on top of all of it, despite our resources not being as they should be. We don't like to see red in charts, and I know that the core due diligence checklist is red, but looking through the report, it looks like it was changed in November and new fields were added. Is this something that will always happen? And I guess my question is this box always going to be red if it keeps changing?
Okay, thanks. And I'll just let Jackie come back, and then Kath, you can come back to in response to all of the points made. Jackie.
I don't have an answer to whether the date will change. I think the terminology is the target date is 1st of July, and that phraseology of it being a target date seems to have been introduced since the change in the deadline. So I think you might draw some conclusion from that. But I think all the messages are that everything is being designed so that the ICB will be established from the 1st of July. The reason I raised my hand is there is a risk that isn't flagged in the paper, partly because it is emerging, which is around we will need to produce a set of accounts for the 3 months that the CCG is responsible in 2022-23. However, our financial services provider, Shared Business Services, are not yet able to say whether they can, the point at which they will merge our financial systems and whether we'll be able to actually rely on the transactions at a CCG level. So it is probably one area in the due diligence checklist that may well move more to red than it currently is shown on there. So I just, given that's the latest information, I just wanted to flag that.
Okay, thank you. And I'll just go to Kath now, and then Leslie, then maybe you might want to say something or not, but I'll come to you after Kath.
Thanks, Matt. So that's useful from Jackie, and I'll talk to Jackie outside of the meeting, so we'll make sure we capture that. Lisa, I wasn't sure which red you were referring to. You're referring to the last page?
Yes, on page 6. The core due diligence checklist, the first one, the green number 1.
That one, okay. So that's one. So out of 352 areas we've looked at, only one's coming out as red. So that felt good to me. I was pleased with that we'd only found one. It sounds like we might have another one based on what Jackie's just said. But there's only one area, and I think it'll be an area. Well, I'm sure it's an area that CCGs across the country and ICBs will be dealing with, so we won't be the only ones.
Okay, so yeah, I think it's great. I think it's fantastic, but I think that keeps changing. So I don't think it's a reflection of the work that's being done here. I just think it's the actual item. Thank you, Kath.
Thank you. And Leslie, is there anything you want to conclude with here?
I think just finally, Chair, so we've covered close down, we've covered the change in the targeted date for startup. Probably just to conclude, picking up the implications for the ICB as well. So I think the ICB will look to establish itself in shadow form, probably as quickly as it is able to do so, and therefore its recruitment of key director posts and non-executive directors continues, and I think those interviews are probably planned for February. So it's just to note that they will continue on the journey and probably operate in shadow form. Therefore, we'll need to look at the ways we bring together our work, where there's implications for the ICB, so planning, commissioning, how we dovetail that in with the emerging shadow arrangements, and how we use our joint committee of CCGs working in partnership with the ICB to be able to do that.
Thank you. So we've noted that, and I think are united in expressing our thanks to the way that this has been addressed and the grip that you and your team, Kath, have got on this. So we're now on to part 5, reports circulated in advance for noting. Are there any points that people would like to make with regard to those? Okay, so we've noted those, which brings us on then to item 17, other business. I've not been notified of any other business. No one has flagged it up. And finally, summary of the meeting reflections. This is something that Terry has brought in. So let me first of all ask, is there a GP who'd like to give a reflection on this roller coaster ride that we've been on, concluding with the hard business of getting ready for transition? Is there a GP who'd like to give a reflection on the meeting? Thank you, Lisa.
I thought I'd volunteer. Yeah, I think we've seen throughout this meeting that general practice is under strain, but we are probably more resilient than we thought we were. And I think that we'll all just keep going, and working in partnership with the local authority and other groups is really helping us. And I think we just need to stick together and keep going and recognise the good work that we've done already and just keep moving forward.
Thank you. And Zach's going to come in. I'm going to put you in the governing body director category, which I think is probably right.
Thanks, Mark. Yeah, I think it's just a reflection on the quality of the conversation that we've had today, and it feels like we've had in a lot of governing bodies. The honesty, the openness with the local population is really important. And I think, we all have a duty to make sure that that continues into whatever new system is being created whenever it is created. It just feels that is really valuable. I mean, it feels a really nice place to be as a clinician that's also got a sort of management role within the system, that we can have that open, honest, transparent conversation. We can be true to values. We can sort of hold the integrity bit. And I think it is really important. It feels really important to me. And I just hope that, whether things are delayed or whatever, I think we are engaging with the ICS and ICB to make sure that that's an absolute sort of core principle. I think we've certainly got that with our colleagues within the City Council and the way that we manage it across the system. But it's just I guess the safe space to have that conversation, but have it in public, feels really important. And to have different views, some of which might not appear to be on message. I think, again, that's really important, that we have the opportunity to have that open and honest debate. So I think it's just to say that I personally value it. I think most of us do. And it feels a really important thing that we have to take forward into the new evolution, into something that's on a bigger footprint. We've got to retain that local bit, because that does feel really important to us. And I think for the local population, which is very varied, and we've discussed that in Sheffield, I think the flexibility to offer services differentially to our local population, again, is really important.
Thank you. And finally, is there a lay member colleague or Health Watch who might like to give a final perspective on the meeting? No. Crit.
Oh, Judy.
Yeah, let's have Judy.
I suppose similar to Zach in lots of ways, I've just been reminded of the real value of equal voices and the value of our clinical voices, sitting on the governing body, but also importantly, the value of our population voices, and that joint working, that partnership working, lots to build on. And I think that the whole meeting really has just been a reflection of that. And I think, Zach, your comments about the open and honest discussion, actually having that in public is well made, and yeah, those will be my reflections.
Thank you. Okay, so I mean, one of the challenges, and it relates a little bit to the point that I think Ben was made a couple of times in different ways, which is that actually articulating some of the cultural ways in which we work in a way that enables it to be transitioned over into new structures is the really difficult thing. How do we describe that and ensure that those of us who are charged with taking things forward actually understand that and make sure that that happens. So thank you, everybody. I'm now going to bring this public part of the meeting to a conclusion by reminding everybody that the next meeting is on the 3rd of March at 2 o'clock, Thursday the 3rd of March. And